So Ken, we know that abiraterone, Zytiga, it's an androgen synthesis inhibitor. It's we, as we've discussed, based upon the 301 and the 302 trials, it has approval in both the pre-chemotherapeutic and the post-chemotherapeutic space. We also know that there is another hormonal agent out there, enzalutamide, which is an androgen receptor signaling inhibitor. Walk us through a little bit your thoughts about the differences between the two agents, what you like about them, how you foresee these agents being used either in combination, sequencing.
I think Mike had a good point about talking about how in the general urology world there may be a fear of using abiraterone because you have to use prednisone and monitor that. But again, it goes back to what we've talked about on the panel, which is if you're a champion or you develop an advanced prostate cancer clinic, then that's just part of the things you do, and it becomes natural. And again, that's all part of the education. So, in that space, we've started with abiraterone just because that's what's been approved by the FDA. I think if enzalutamide gets that approval in the pre-chemo space, I think it will definitely challenge that early on just because of the lack of needing prednisone and the active monitoring. But we've been very successful as that patient has progressed, starting them on this, setting up the monitoring, and patients have done remarkably well. And again, it also goes back to patient compliance. You have to tell people, hey, this is important to take this medicine. I think there's a natural feeling by the patient, hey, this really isn't chemotherapy because it's a pill. But I think it goes back to educating the patient that this is chemotherapy. It is important to take on a regular basis with prednisone, and then ultimately, educate them. And they've had great success with it. Again, I think enzalutamide in that space, when it gets FDA approval, if it does get FDA approval, will definitely probably move earlier on.
I mean, Neil, don't you think that that's this whole prednisone issue, this reluctance by the urology world to give 5 milligrams once or twice a day of prednisone is, to me, I think is completely blown out of proportion. I mean, that's a very small dose of prednisone it's a physiologic dose of prednisone almost.
Yeah.
I mean, you've given a ton of Zytiga and Abi.
So, it's an interesting phenomenon about, you think back to, can we teach an old dog new tricks? I think back to the idea of when zoledronic acid was approved, how urologists were very reluctant to cannulate a vein, a peripheral IV. We operate on the vena cava, retroperitoneal lymph node dissections, but cannulate a vein in the clinic? No, we're not going there. Right. But we've kind of overcome that. We give intravesical sub-Q IM. And then, to your point, and I think Philippa and Oliver were saying this, it's a team approach. We have to evolve into the concept that advanced therapies is more of a team approach. It's not just the clinician, it's the supporting healthcare providers, nurse, physician assistant, and administrative support. New ways of ordering drugs. You can't go down to the corner drugstore to get your prescription filled. Have to go through specialty pharmacy, or getting a PET scan, filling out a 2-page paper and getting your PET scan approved by Medicare. And likewise, prednisone. I mean, 5 milligram twice a day, or in some folks, and that's the labeled indication, is twice a day. Myself, I'm typically 5 milligrams once a day. And there's even some data that suggests not everybody even needs to get the prednisone. But that said, it's just about becoming comfortable with new things. And if we're not going to become comfortable with new things, then we really will relegate ourselves to anachronism, and not just in urology, but in everything. So I think discussions like this are so important, and we were talking about this at the break, and why does this not happen? Well, because everyone's so cramped for time. I call it, there's a limitation of frontal lobe space and of accessibility. But this is not rocket science, I think was said, to give prednisone twice a day. It's just something new. And the drug has benefits post-chemo, pre-chemo. It's reimbursed by all Medicare carriers. Checking a potassium level or an LFT, I mean, we can do these things. And most importantly, we do it because it benefits patient care.
And although we're talking about Zytiga, I've met colleagues who have anxieties about prescribing enzalutamide because of the fear of the patient having a seizure, and yet we know from the recent ASCO data presented earlier this year that the incidence of seizures on enzalutamide was so minimal and very similar to the risk of seizures in the placebo group. So it's not just a question of fear over prescribing prednisone with Zytiga, it's fear of the unknown, and that's global in this field, particularly with this field moving so rapidly. And I think people who are not familiar with managing these patients, even if they get a handle on what the current state of play is right now, it's moving so quickly that will I be able to keep up to date in 6 months' time? And am I going to be left behind the curve trying to manage these patients' standard of care in the medical oncology setting?
You know, and again, I think those are great points, because again, this is everything we're talking about is you have to have a complete understanding of these drugs, mechanisms of action, side effects. I think the one thing that I worry about in smaller practices is people, again, like you said, this is not about writing a prescription and take it down to Bob's drugstore. You know, there's specialty pharmacies involved. It's also, this is not like writing an anticholinergic and an antibiotic and seeing a month later. You know, there are some specific things we have to be monitoring. And again, I think the understanding of the mechanisms, the regulatory, the reimbursement issues, all these things, because again, you know, we are the ones responsible for managing these patients. So,
and although these patients are being treated with medications from specialty pharmacies, I've been overwhelmed by the amount of support there is out there to help people, to help their patients get these drugs to the patients as quickly as possible, particularly with Provenge, with getting Zytiga, with getting enzalutamide. And it's just knowing who to go to get that support in setting up your practice to offer these to the patients.
And I do think, like Oliver said, it's important to educate our office staff as well, because I think, like Neil said, there's that fear of how much can I do if I have to fill out paperwork and get all that. So I think it's critical, if you're going to run an advanced prostate cancer clinic, you've got to either have an advanced nurse practitioner, physician's assistant, office manager, et cetera, to help us with that process. Because again, I don't think we have the time to do it, but again, it's part of the critical team effort to get it done efficiently.
But to that point, I would say that setting that up can take some time, and it needs some dedicated effort. But it gets to a point, like, for example, now I can just say this person's going to be starting abiraterone, and my staff takes care of everything else. I don't have to sit there and think about what other form I have to do. Matter of fact, I don't even know what forms are being done. It's my staff has just figured all that stuff out. They've been trained well, and so it's gone from there and made it a lot easier.
So we've mentioned